As you know, that we have right now the special newborn care units for the newborns, small and the sick newborns. We have 1,000 plus special newborn care units across India. And as we are moving forwards towards the better newborn care unit, newborn care, and the emerging evidence, and one of the important criteria which we are having, the strategy we are adopting, is the establishment of the mother newborn care unit with the concept of zero separation of the mother and the newborn. However, we came out with the guidance note on 2018, which had some different some guidance note. However, with the emerging evidence, there are some variations which are coming from the those guidance note. So we have now much more clarity how to set up, what are the requirements of the infrastructure, how to go about the clinical processes and the potential benefits. So it is now evidence based that these units are a important milestone when we want to achieve the quality newborn care reaching till the last mile. So we were getting frequent requests from our states that how to set up these mother newborn care units as per the new guidelines. So though we have included in our revision of the guidelines which we rolled out, we have one chapter, but to have a better clarity on this, we have with us Dr. Harish Chalani. Sir is he was the principal investigator of this study when it was done, the multi-country study, and Safdarjung Hospital was one of the sites where it was conducted in 2017 and 2018. Dr. Jyotsna Suri, she is the obstetrician and the gynecologist who was involved in this, along with Dr. Sugandha Arya. She is also running this mother newborn care unit right now in the outborn nursery of the Safdarjung Hospital till the level 3 care, where mother and the newborns are kept together and they are provided the quality care with the involvement of the mother. So mother is not mere a visitor, rather she is a partner and she is a part of the mother of the newborn care which is being provided. So not taking longer further, we have with us and this vision of expanding these mother newborn care units across India with at least every district having one mother newborn care unit. Our joint secretary is really enlightening and guiding us that how to take it forward with timeliness and the targets on a timely basis so that we are able to achieve our targets. So for now, I would request Joint Secretary Meera Srivastav Madam to please enlighten us and all the gathering about this. Over to ma'am.
Thank you, Shobna. Shobna, can you hear me?
Yes.
So good afternoon to all of you. As all of you know that maternal, neonatal and child health survival are the highest priorities of the government of India. Our nation has made really remarkable progress in improving the health of mothers and children. And this is reflected in the statistic itself, as our mortality rate under 5 has reduced from 45 per 1,000 live births in 2014 to 32 per 1,000 live births in 2020. We are also happy to report that the number of neonatal deaths have reduced from 13.5 lakhs per annum in 1990 to 5.5 lakhs in 2020, which is nearly 65% reduction in India as compared to 51% global reductions. As far as the government of India is concerned, we have taken many significant steps, including establishment of 1,054 special newborn care units at a district and sub district levels, where 14 lakh small and sick newborn were admitted during the year 2023, and I'm happy to know that they had 83% successful discharge rate. So in an effort to achieve zero and minimal separation of the mother-baby dyad at these SNCU, Government of India has released guidance notes in 2018 for establishment of the mother-newborn care units. And also research was conducted in MNCU Safdarjung Hospital in New Delhi. And evidence is showing very, very promising results that there is a significant reduction in newborn mortality and improved outcomes with this measure. So this model has some variations as far as the guidance from government of India, and that needs to be taken care of when we are establishing the new MNCUs. And since this is establishment of these units is one of the important achievements to reach our SDG goals, so therefore we have all assembled here today for an online orientation meeting in which the experts from Safdarjung Hospital, I am so glad that you could join us and be here with us, Dr. Harish Chilani, Dr. Sugandha Arya, along with Dr. Jyotsna Suri, who will share their insights on setting up of the MNCUs, along with discussions and on opportunities and challenges which might be faced during the implementation process. So I do hope, because of this measure being so positive and will have such a profound impact for saving the life of small children, I do hope that we will have a successful rollout, and I wish all the best. I hope the meeting is very successful one, and I would really request all of you to understand the concept and ask as many questions and queries from the experts who have kindly given us the time and have shown keen interest for disseminating their knowledge and will help us to understand the setting of NUNCU's better. I also our child health division will note the proceedings and also incorporate the same in the learnings for the upcoming revised FBNC operational guidelines. So I request that please all of you participate heartily, and so that this whole meeting becomes a process of a constructive dialogue, and we will have much to learn and gain from it. I thank all of you for joining here and being here with us today. Thank you once again.
Thank you so much, ma'am, for your inspiring words. And definitely this effort, we should move forward in setting up of a good MNCU and taking our newborn care to a next level. Thank you so much for that.
Thank you.
Now we will be moving forward with our main session, in which Dr. Harish Chalani, sir, as I told you, was the main, is not only was a PI, in fact, after that, he has been mentoring not only in India, but even outside India in various projects in his capacity as a consultant, and helping the countries to set up MNCU in their countries, in their setting, in the context specific setting, and how to bring about. So he will be talking also, on mainly on the how to set up, and if you have a NICU or you have a SNCU existing, then what measures can be done, and what are the different possibilities. So now we will be hearing from this sir. Over to you, sir. Thank you for being here.
You have changed this one? Or slide change?
Slide.
Okay. So just thank you, JS ma'am, Madam Meera, Dr. Shobna Gupta. It's really a pleasure and honor for me to present along with Dr. Jyotsna Suri and Dr. Sugandha Arya on the new evidence of the KMC and the setting of the mother newborn care unit. As it was mentioned in the introduction, that we are looking for a zero separation concept. And there are challenges, but when we talk about the zero separation, it means right from the time of the birth till the discharge, or even to continue this, zero separation even at home. So what we are looking is that beyond the facility, that this concept to continue even at the level of the home. There are hard evidence associated with it. Fortunately, Safdarjung Hospital from the whole Asia conducted this trial, which took the MNCU concept into the picture, which we are going to discuss with you. But there are some opportunities, challenges, and the role of the obstetricians in this whole collaboration, which is very crucial That's what we are going to discuss in this session. Oh, sorry. Sorry.
Change to one slide. It's a shift.
Yeah. पिछली वाली slide. So friends, as we all know that in India, more than 24 million births are happening. And we also see there is a significant amount of mortality which is happening. And if we see, there are two areas in which we are having the maximum burden. That is the care around birth, and that is another is the mortality amongst the low birth weight and prematurity. We do have the strong interventions, and we also know another fact that majority of the deaths which are happening around the time of birth or among the small and low birth weight babies, these are preventable. What we are going to touch today upon is a major portion which constitute around, towards closer to 50% of the deaths which are happening among low birth weight babies and among the premature babies. Kangaroo mother care, we all know, is a strong intervention, and that is only should not be taken as a vertical intervention, but part of the care package. We have recently evidence in favor of kangaroo mother care, new evidence which has come. Now, till now, we know in the last 2 decades that kangaroo mother care is to be initiated only at the facility level, and if it is to be initiated among babies below 2000 gram babies who are stable, that means who are not sick. So we wait for usually 24 to few days till the baby becomes stable. And Cochrane meta-analysis has shown it reduces mortality by 40%. Along with reduction in the mortality, we also see that there is a reduction in the sepsis rate, hypothermia rates, and there are better breastfeeding rates. But though this has been the guidelines for last 2 decades, but there are 3 research gaps which we had. One, the coverage. If we see global coverage is very low, it is just less than 5%. And we had the study which was published and which was done in the India and Ethiopia, which showed that coverage can be improved. And this you can see in the slide that this is to the tune of 60 to 80% KMC coverage on day 8. Similarly, as I mentioned in the opening remark, that KMC was to be initiated only at the facility. But what about those babies who are stable and they are born at home, or they are discharged within 12 to 24 hours from our SNCUs without getting the KMC initiated amongst the low birth weight babies? So, but now we know that if we initiate the KMC at the community level, there is a 30% reduction in the mortality. The third gap which was there, that waiting for the stability to happen. And believe me, that when we looked up the Cochrane meta-analysis, it varied from 10 hours to many days. And 3/4 of these deaths, they are happening within 1 week. And 50% deaths which are happening in the first 24 to 48 hours. So does KMC, which when we start immediately after birth, does it save lives? That we are going to discuss, and that basically brought out the concept of the mother newborn care unit. Next slide. So it was a study which was done in 5 countries. It was a randomized controlled trial, and in the whole Asia, India was the only center, and Safdarjung Hospital was the center which conducted this trial. And the population which we use, generally below 1.8 kg is the cutoff of that, the birth weight which are admitted at our SNCUs. And generally babies who are below 1 kg, they are referred to the higher facilities or tertiary care facilities. So that's the population which was used, and the intervention in which the KMC was started soon after birth, right at the birthing place. And control group received the KMC in the conventional way, the way after the stability, the baby is shifted to the KMC ward. Next slide. The intervention which was there, that KMC was started within 2 hours of the birth, and we aimed for 20 hours per day. And because these babies are with the mother, because when you are expecting the KMC to happen more than 24 hours, these mothers, they have to be with these babies almost 24 hours. Only then you can provide that amount of the kangaroo mother care. So immediate postnatal care was also supported, and the exclusive breast milk feeding, because as you know, these are small babies, and we wanted to start the express breast milk feeding to those set of babies who are unable to suckle directly at the breast. Next slide. So to operationalize the concept of the KMC starting at birth, and even these babies in the labor room or in the OT, KMC was started within 2 hours of the initial resuscitation which was done. The KMC was started, and even the babies, the sick babies, were transported in the KMC position. And if suppose mother is unable to provide the KMC, because the obstetrician colleague, they do want to observe these mothers, then the surrogate or some of the family member provided the transport. And to provide the KMC of such a large duration, we created the concept of mother newborn intensive care unit. That is the presence of mother inside our current NICU. And once the baby gets shifted from the stable, from there, the baby was shifted to the KMC ward. Next slide. So this is what you can see, the picture of the mother newborn care unit or mother inside the NICU, where each bed of the baby, that's radiant warmer, there is a mother's bed. There is a nursing station which you can appreciate in the center, and there is a KMC chair. So this is a level 2 care facility with all provisions of oxygen suctioning. So this is a 12-bedded unit which we created. We can see in the next picture, next slide, the one of these unit. Can we have the next slide? So you can see this 12-bedded unit which is there. So show the picture of the one unit where you can see the presence of the mother's bed, which is adjustable head end, and you can see the CPAP unit, presence of oxygen, suctioning. So all the facilities which you have in the MNCU, these facilities were created along with mother's bed. Next slide. Because mother is there with the baby, or the family member who plays the role of a surrogate also stays in that unit. So the support services for the mother, the washroom, the bathing area, or the mother's examination room was also created. Of course, we are going to show you the video. We will take you through the whole virtual tour of this unit, but just to explain you that the infrastructure for the care of the mother was also created. Next slide. So let's see the results. We had a very large, next slide, the large cohort of 1,600 babies on both the sides, the intervention and the control. When I say intervention, where the baby received the KMC within 2 hours, and we aimed for 20 hours per day for even sick babies. So you can see that in the intervention group, the median time when the KMC was started 1.3 hours, whereas in the control group, it is almost 53.6 hours. That's the time usually takes on the median side when we see for the stability to happen. And the second bar which you can see, around 17 hours, the baby received the KMC in the intervention group, whereas only 1.5 hours the KMC was there in the control group. Once the baby gets shifted after 5 to 7 days from the MNCU or level 2 care of NICU, these babies were shifted to the KMC ward, where you can see the duration of the KMC is almost 19 to 20 hours. Next slide. This is very important. Now, what is the outcome of these babies? What we looked at, that the death between the enrollment, that is within 2 hours, and up to 28 days of life, that is the neonatal period. When you see the intervention group and the control group, see the number of the deaths which are there in the intervention, which are far less as compared to control. And when we say risk ratio of 0.75, it means 25% less mortality in the intervention group as compared to control. And we also looked up the hypothermia rates. There is 0.65 ratio, means 35% less chance of hypothermia in the intervention group. Now, there is always an apprehension of the infection which is carried by the mother in the MNCU. But on the contrast, what we found that 18% reduction in the suspected sepsis in the intervention group. Next slide. After these 3 gaps which were there and the results from the immediate kangaroo mother care study, which was published in very prestigious New England Journal of Medicine, the World Health Organization revised their earlier guidelines. And now, as we all know, they were published in November 2022. They are quite recent. And now KMC is recommended for all preterm or small babies who are below 2.5 kg. Earlier, we had the guidelines for below 2000 grams. Then it is to be started as early as possible without waiting for the clinical stability to happen. And now one can see that it can be initiated at home setting also, and KMC is to be given for minimum 8 hours. You can aim for even 24 hours, but for effective KMC, it has to be 8 hours. Next. Now, when we look at the setting of the mother newborn care unit, as you must have seen the document of the SNCU toolkit, there are services which are defined. What is the civil infrastructure which is requirement? What is the equipment, budgeting, manpower, and there, of course, training. Next slide. So what you can see that minimum space, which in the SNCU, which we have defined is the 100 square feet, which includes both the baby area as well as the ancillary area. So for a 12-bedded, we find it is around 1200 square feet area. But in the one you keep the mother's bed area, you add 100 square feet. So it almost amounts to 2400 square feet area. This we talk about the minimum. And then this is the design which you can see. The yellow columns which you can see, these are the mother newborn care bed, the one cubicle which I showed you. And in the center, you can see the nursing station. There is an entry, the triage area, the hand washing area. Then in this design, you can see for 12 mothers and 12 surrogates, if we presume, there are 2 washroom and minimum 2 bathing area, and nursing station, the doctor's duty area. So all this we have, which you will also see in the operational guidelines, which will be released very soon. Next. So when we looked up the equipment, most of the equipment belongs to the same. Next slide. Where on the left-hand side, you can see the same equipment. When we see the LED phototherapy or the CPAP unit, roughly in a 12-bedded, we say around 25 to 30% of the babies, they do require either CPAP or phototherapy. So 4 machines of CPAP or 4 phototherapy units would be required for level 2 care. But if you see, and for the mother, we will require the KMC chair, we require the mother's bed, and vital sign monitor, I would say here optional, because you will hear from our obstetric colleague that only the stable mothers are kept in the MNCU. And definitely, we would like to have the KMC governments, which we'll show you in the video also. These are very essential because these are sick babies and the neck has to be kept in the slight extended position. So that's very crucial. As far as the human resource is concerned, the almost the same staff which will be required, we will discuss with you in the question answer session. In fact, the work of the nursing colleague gets reduced by 50 to 60% because mother is involved in the care of the babies. So a lot of the activities are done by the mother herself. Next slide. So when you no previous slide. So when you plan the MNCU, plan the location of the MNCU which is quite close to the labor room or the OT. It should not be in a different building. Preferably, it should be on the same floor, the OT, labor room, and the MNCU. Calculate the space based on the number of beds. Now, roughly, if you have 3,000, the delivery is happening, or 30% extramural births which are coming up. So this, and on an average of 5 to 7 days stay, this constitutes about 12 beds, which is there mentioned in the our operational guidelines. But sometimes I would request you, the moment you start saving the babies, your the service from the extramural admissions that increases, and we should therefore keep the scope for expansion also. Then also plan the list of the equipment, even the emergency trays, because sometimes you don't know. So crash cart is very important. Also discuss the human resource and the training, which is, now of course, the Ministry of Health and Family Welfare is going to plan for all the states. Next slide. So now, if we want to scale it up, so it is very important that these WHO guidelines, they have to be the part of our national guidelines. That part has already been taken care of by the Child Health Division of the Ministry of Health. Then second important thing is, wherever you have a space or you are going to develop the new MSNCU, then try to create the guidelines as per what we have been discussing. Otherwise, please try to find out, discuss with the obstetric colleagues. There will be some space from where you can make the MNCU unit. And it is very important that the immediate kangaroo mother care, this is basically entry point for the MNCU, that try to be put into our health system. Friends, we have been doing the best what is have been taught to us till now, that sick babies have to be taken care in the radiant warmer. But with this new evidence which we have, we should now change it to the zero separation policy right from birth. Fortunately, with our Lakshya program, we are allowing already the companion in the labor room. But if this companion, or what I would say, this companion best is the mother in the NICU, then this becomes the actual zero separation concept. Next slide. So if we want to do it, naturally as a policy, which we'll have to change. So current policy at all these SNCU is that mother stays in the postnatal ward. So that has to be changed, and we have to allow the mother or surrogate. Why I'm saying or surrogate? Till the time mother can reach to the NICU. So or sometimes even for the twins, the surrogate is required, or even for the time when mother is sick, mother is not available. So that's the time when you require. So this concept is basically going to revolutionize the way currently the neonatal intensive care is being practiced. Next slide. But before we go to that, we would require the amount of training. It is very important how to provide CPAP or oxygen support or tube feeding in the KMC position, because these are sicker babies. How the binder is to be placed, it requires a training. So we would be requiring all the components in the training. And the next slide, very important, that strong obstetric neonatal collaboration is very crucial, because obstetric team has to come to the NICU to take care of the mother. So that kind of a couplet care which we are looking for. Next. Now this is another way forward. Are we looking the zero separation only for the low birth weight babies, or we are looking for all babies? So recently, which we will show you also in the video, that Safdarjung Hospital has replicated this model of care, not only for the low birth weight babies or preterm, but every sick babies who may require the tertiary care. But since we are now looking for the MNCU level, I would say every small and sick baby should be with the mother, and that should be the norm. And we should involve the mother as a caretaker, not the visitor. So I would stop here, and we'll take the question answer session later on. But I would like the video to be run so that you can see. It's a virtual video. You can have the view. This we made it during the time when we conducted this trial. It's a 5-minute video. Please keep writing your questions. We would be taking them at the end. Okay, okay. एक बार पूछ लो.
शेयर होगी ना, शेयर स्क्रीन में
मेरे को क्वेश्चन आंसर सुगंधा ये स्टार्ट कर.
Sound missing. Thank you, sir, for providing the insights, how the evidence came and how to establish the MNCU. And I'm sure there must be many questions. Some people probably are not able to hear the sound, but I'm sure the video played showed them the glimpse of how the mother newborn care unit looks like and what all services are being provided. And as we move to the question, and now we'll be moving to the next session, and Dr. Sugandha Arya could be discussing about the challenges. Definitely, no new thing is easy to come by. So there are definitely many challenges which come over the journey, and whenever we want to scale it up, so same issues might be coming up with many of you. So we'll be hearing from her that what all common challenges they encountered and what are the solutions to overcome them. And definitely one day cannot be sufficient for overcoming those things, but as we move forward towards this journey and setting up of MNCU all over, so definitely these things would help. So over to Dr. Sugandha Arya for the next session, and we'll be definitely taking the question answers at the end. You keep on typing on the chat box so that the many questions might be common, so they'll be taken simultaneously. Now, Dr. Sugandha Arya.
Thank you, Dr. Shobna. Good afternoon, everyone. So Dr. Chilani has already set the stage that how MNCU came into existence. It was IKMC study which gave rise to this concept of mother newborn care unit. And then as we, besides that, he also discussed if you are planning to set up a mother NICU concept, then how to set up. I will be sharing with you our experiences, the challenges we faced while setting up mother NICU. We are running our inborn mother NICU since the study started for last 6 years. And now we are running outborn mother NICU, which you have seen in the video, since August 23. So what we have realized, there are a lot of challenges, not only setting up mother NICU, but there are ongoing challenges also when this mother NICU unit is being run. And it is not only the challenges, there are a lot of good opportunities and which actually show that these challenges are worth facing. So when you are planning to set up an MNCU, what are the major issues and concerns? So basically the challenges we face, you are also likely to face. The first most challenge is against the current norms. Creating a mother's bed in the NICU, we all are used to having a newborn care where babies are inside. Mothers are either in the postal wards or at home, and they visit intermittently. So changing that mindset against what is we are used to is the first challenge. Then provision of respiratory support in KMC position. If we are having MNCU, then immediate KMC, many of the babies will require respiratory support because many of them are preterm. And then I will be discussing that challenge, how we countered that challenge. Another very important challenge we are going to discuss with you, which I'm sure it's going through all of your minds right now. And you will be facing this question from many of your colleagues, that what if mother comes inside ICU? We are so obsessed with asepsis, then how are we allowing even the outsiders? Obstetricians to take postnatal care inside NICU. These mothers have just delivered, and this challenge will be taken care by our obstetrician, Dr. Jyosna Sudi. Another challenge, which sounds simple, but it actually happens, increased accountability of healthcare providers. We are all used to working with the newborns in the absence of parents. They don't see how we are taking care. Now nursing care by doctors is all happening in presence of mother, and this gets an insecurity among healthcare providers that now we are more accountable. Next slide. So infrastructure setting, I will not go into much of this challenge. Dr. Chilani has discussed with you in detail, but this is the first challenge to start with, that you have to establish the infrastructure, equipment, setting up the mother newborn care unit. And as I told you, also taking the administrators and policy makers. There are so many administrators and health system people in the meeting right now, that their convincing and their collaboration is also very important to start a new unit. Next. This also has been discussed, but here just I want to focus one point, that we are already running SNCUs, special newborn care units, which are level 2 units. MNCU is exactly the same level 2 unit, whatever is being run. So newborn services remain the same, newborn infrastructure, equipment, everything is same. The only addition in each cubicle is the presence of mother, for which you need a bed, KMC chair, as it was discussed. Rest of the things will remain the same. Now coming to this challenge, when we started study in 2017, 6 months down the line, we really struggled with this. Providing respiratory support in KMC position, it will get dislodged, the tubes will come out, and this will make the mother hassled, healthcare providers were getting hassled, that how we will provide a good respiratory support in KMC position. But let me tell you with experience that as our sisters started doing it and practicing it, now they are very comfortable with this. So once it comes into the system, hands-on training starts, it is very, very workable. But there are some important points you need to keep in mind. Next. So if you want to optimize respiratory support in KMC position, actually, most of the points are same which we do in the radiant warmer. The same principles apply, only the place has changed. Earlier, the baby was in radiant warmer and now he's on mother's chest. But otherwise, the same principles remain. Maintaining airway, neck has to be in slightly extended position. And for that, binder is a very, very useful thing to use. So must use a KMC garment with a binder, which we have shown. I'll be showing in the next slide later on. And so maintaining neck in the slightly extended position, that will solve most of your problem to give effective CPAP. Then as you optimize nasal interface for CPAP on a radiant warmer, you must optimize here also. Nasal interface, if larger or smaller than what is required, it is going to get dislodged or leak. Another challenge is proper fixation of the baby in KMC. When you put a baby with CPAP in KMC position, then how to fix up the tubes and all so that there is not much dislodgement. So this is more of a skill which comes with training and practice. And very important for successful CPAP, even in KMC position, you must monitor the baby's SpO2 and heart rate continuously when the baby is in KMC position. As you can see in previous slide, can you just focus previous slide once again? You can see on the left side, the monitor is going on. The advantage is that you are looking at saturation and heart rate all the time. And if there are minor changes in heart rate or saturation, actually, for saturation, you can change PEEP and FiO2 minimal changes right in KMC position without separating. So your timing of separation, only if there is a sudden deterioration, you should separate out and see the baby and see the reason of the deterioration. Next. Next. So this is the KMC. You have seen in the video very well how they have done that. So binder component, its purpose is to keep the neck slightly extended position and bind the baby to the chest. And KMC shirt over that also gives additional support to the baby and also gives a mother security of, being covered. Her areas and chest is not exposed by putting over KMC shirt. So it makes her more comfortable. So this is a good. And this KMC garment is now available on GEM portal, government portal. So all the government hospitals actually can get this through government supply. Next. Next challenge, concern about infections. Even when we started the study, the same thing we also faced. And even today, after running MNCU for almost 6 years, we still get this question very often as new people join and show their apprehension. That if the presence of mother inside ICU 24/7, are infections going to increase? So after this IKMC study, we actually did a post hoc analysis to see what is the effect on neonatal sepsis by continuous 24/7 presence of mother and surrogate in newborn intensive care unit. Next. And as you see the results, even the primary study, which Dr. Chelani also told you, the primary outcome also showed that it went against our apprehension. We were expecting no increase, but actually the neonatal sepsis reduced by 18% for the babies who were staying in the mother NICU during the study. And when we did post hoc analysis, we had some very interesting findings. And not only sepsis is less when the babies stay in MNCU, they die also less of sepsis. Sepsis-related mortality was 37% lower in MNCU. The reason for this were multiple. They were getting more breast milk. Breast milk has a very protective mechanism. Then better monitoring and very interesting finding, although the sample size was small during the study, the bacterial isolates were different in the conventional ICU and mother newborn care unit. There were more gram-positive in mother NICU, which were less resistant, and more resistant gram-negative in conventional NICU. This might be one theory of maternal microbiota coming into picture and protecting these babies from nosocomial infections. So what we realize actually that forget about the apprehension of increased infection. Actually, immediate KMC can be used as an effective infection prevention control tool when we are heading for an era of multi-drug resistant organisms, which I am sure is happening at the district level also. So this might be one of the very good answers to counter this problem. Next slide. As I mentioned in the beginning, a lot of challenges setting up a unit and lot of daily challenges in running the unit also. In conventional NICU also, we have a lot of challenges. In mother NICU also, we have a lot of challenges and some in addition because of the presence of the mother. But the opportunities you are going to get once you start running this unit and see the opportunities, you will find it is worth facing the challenges every day. But we find that in MNCU, since the mother is not a visitor, she's staying 24 hours. She can give prolonged, effective, continuous KMC to low birth weight babies, even when they are on CPAP. So what we found during the study, the mothers who stay inside MNCU, they give median time of KMC of 17 hours. And in NICU, when they visit intermittently, the median time, in spite of a lot of counseling, does not go more than 1.5 hours. Next slide. And it is also very obvious if a mother is coming to the NICU right after birth or within few hours of birth, and then she's going to stay with the baby, she is going to have better lactation because of the presence of baby around her. And at the same time, she gets a lot of opportunities to feed the baby. Health personnel had a lot of opportunity to get breast milk for the baby. And as was expected during the study also, we found from the data that initiation of breast milk feeding, putting the babies to breast, reaching full breast milk feeds, and then discharging on exclusive breast milk feeding was statistically significantly higher in MNCU, which was very, very expected outcome when we started MNCU. Next. And not only this breastfeeding, reduce infections, there are a lot of other opportunities you get by MNCU. As Dr. Chilani said, zero separation. If we are aiming for zero separation, there is no way you can create zero separation by getting the mother visiting the unit, whatever counseling you do. Zero separation is possible only if mother stays inside. Mother is taking care of the baby. It results in a lot of family-centered developmental care. And what we have realized with our experience, mothers can be trained to follow asepsis routines. It is only you need to train them. And you will find this strange or that we find that mothers follow asepsis routines much more diligently than even healthcare personnel. Because healthcare personnel, there is a fatigue effect. They are doing the same thing for years and daily. But mother has only one baby and she knows that if I don't follow, the baby is going to get sick. The moment you tell her, she sometimes even mothers remind us to use the hand rubs and all. So it is very useful to train the mothers to follow sepsis routines. They will monitor the neonates. They will report the danger signs immediately. And as a result, whatever they have learned while staying in MNCU, they are able to deliver this when they go home after discharge. Then as I discussed in the previous slide, mothers get a lot of support for breastfeeding and expression of breast milk. As doctors go for the rounds, mother is by the side of the baby. So we get a lot of opportunity to talk to the mother, to help the mother in helping her out in breastfeeding. Similarly, nurses during their nursing care, they get a lot of time to interact with the mothers and support them, even SOS. Another very important thing and significant finding and which is a very, very good, our outcome of MNCU is mothers have less anxiety, less stress, less depression when they stay inside NICU. Because otherwise they always have a stress staying outside, what is happening inside, seeing the baby across the glass doors or seeing the baby 2 times in a day. they get that. And even a study has been done by a PhD student where they have done salivary cortisol levels in the mothers and the babies to see the stress. And they found that the mothers and babies have significant, even the babies, they have less stress when the mother and baby stay together. And parents feel very satisfied and mothers feel very empowered that we are being involved in the care of the newborn and we are able to do that. Next slide. So as we see that when mother gets the opportunity, she becomes a primary caregiver. And actually, almost half of the nursing care is taken over by the mother changing the diapers, breastfeeding the baby, palliative feeding the baby. And by this, we also have less risk of cross-infection because nurse will take care of 12 babies. Now, every baby has his own nurse. So cross-infections issue becomes lesser. And definitely, this is a very developmentally supportive care where there's a continuous touch with the baby, caressing them during the feeding, during the painful procedures, and swaddling them whenever required. Next. As I discussed, that our opportunities for counseling mother is a lot because all the time mother is inside. So during the rounds, during the nursing care, the whole day when we are taking care of the baby, the mother is seeing us, learning from us, and then you can make the mothers do in front of you also. So before she goes home, she's actually prepared for feeding, temperature regulation, looking at danger signs. Otherwise, what happens in NICU when the babies stay and on the last day when you hand over the discharge, you tell 6, 7 things to the mother, 1, 2, 3, 4. But they have never practiced that. They have never seen doing that. So they do not grasp that. But here they see, they learn, they practice, and then they go home. And this should go a long way in reducing the post-discharge neonatal mortality because mothers are going well prepared home. Next. So zero separation is probably a fundamental right, I feel, for the mothers and the newborns. It should come as a legal right for the baby to be with the mother. And if we are aiming for zero separation, then we have no answer but to have a mother newborn care unit, and which needs establishment at various centers at various levels, as you all are here, to help out this rolling out. Thank you so much.
Thank you, Dr. Sugandha, for providing the insights on the for providing the insights on the possible challenges which will emerge. However, the solutions and the advantages which we see, the opportunities, I think they far outweigh these challenges, because once the process, always a new process, it takes a little time to start with. But once it becomes a routine, then it becomes a normal for us. So as we started with the special newborn care unit initially, definitely there were challenges. So similar this way as the first and foremost opportunity which we can see, the mother is the caregiver. So there is one nurse, one mother for every baby. I think that is the highest advantage. So as we know that mother is a part of this mother newborn care unit. So definitely it's very important to have the obstetrician point of view, that what care the mother, because the mother is also a postnatal. So what possible care the mother would be requiring, and what could be the challenges while caring for the mother. And that is many a times a question for all the pediatricians also, that how that collaboration would work. So I have with me Dr. Jyotsna Suri, who is actively doing this for last 6 years at the Safdarjung Hospital, and she has made this possible with her team to overcome these challenges. Over to Dr. Jyotsna for the session.
Thank you, Dr. Shobna. And it's a real privilege and honor for me to be presenting the obstetrician's perspective in this very important forum where all of you have joined this afternoon. So when I think you have already got the concept about the MNCU from Dr. Chalani and from Dr. Sugandha, and all my obstetrician colleagues who are here this afternoon logged in. So the question in all your minds will be how this is feasible. How will we do it? Who is going to see the mother? Where is the space? How do we provide for the mother? So I think, I'll just run through this and then we'll be happy, of course, to share, to have your questions and share our, experiences with you. So please, the next slide, please. Yeah. So when I'm going to be talking about this, I will take it in 5 points, the 5 challenges for operationalizing, the MNCU and the immediate KMC and the KMC. So first of all is the initiation itself of the skin to skin contact right in the labor room. And of course, there are babies who will be, requiring the immediate KMC also because they are low birth weight. So this is the first challenge because we are inside the labor room and we have to initiate this whole process. The second will be transportation in the KMC position to the MNCU. The third, which I will be talking about, creating a mother and baby friendly infrastructure within the MNCU, and then coordinating with your pediatric colleagues for the couplet care and ongoing training of staff, both for. So next slide, please. So the first is initiating the KMC in the delivery room. So the skin to skin contact, every, I'm pretty sure every facility is doing the skin to skin contact of the baby with the mother just after the birth. And the delayed cord clamping is, I think, also being done by all facilities. So this process is already, we are familiar with this process. And now what is required is that this process of skin to skin contact should remain, not just for a few seconds or minutes, but for a much longer period till the baby and the mother are within the labor room. We should try to make it happen. There are the babies who will be small babies and, initiating KMC with the mother or the surrogate and transporting to the MNCU is a challenging job as far as the obstetricians are concerned, as well as the pediatrician. Next, please. Next, please. Yes. So first of all, identifying the mother who is likely to have a small baby. So the low birth weight baby, many times, we already know they are in our antenatal book cases, but at times they come in labor, referred from somewhere, and we have to actually at that time, it's, patient will be in labor. So once you identify this is a low birth weight baby who will be born, so it is important to counsel the mother as well as the family that this baby will be needing the KMC. And, this, if the mother is not able to go, for the KMC immediately, we will need to identify a suitable surrogate who is culturally and socially acceptable. So in our own hospital, we are only taking the close relatives because those are the ones which are accepted by the patient, and a female. We are not taking the father as a surrogate, which is also, internationally a norm that father can be a very good surrogate, but that I think part can be in the home setting when the baby is discharged, but in the hospital with the closed cubicles and the issue of privacy, we are only taking the lady relatives as the suitable surrogate. So we have to identify a suitable surrogate even before the delivery takes place in a low birth weight baby, and then designating a KMC area with bed and chair within the labor room. So you saw a very beautiful video of our MNCU. You saw Dr. Sugandha telling you about the garments. So how the baby is bound to the mother in a safe way. All these things you have already seen, but we need an area. So this is the responsibility of obstetricians to identify this area within their busy labor room. And the beds, I will show you the next picture. So if you have got the LDR beds, you can please change to the next slide. So if many of you will be having the LDR beds in your centers, in your facility. So it is very easy to start the KMC on these beds after the delivery. On the same bed, the patient can deliver, and then you can put the head up at 45-degree, and the baby can be, initiated with the KMC with the mother right within the labor room itself. So this is about, how a very important point. I think every one of our obstetric colleagues should get these kind of beds in their labor room. Next, please. Yeah. And then the transport of the mother, or the surrogate, it may be either of them, from the delivery room to the MNCU. So here the logistics come to play because we need extra staff for this. And you need, of course, the mother, you can, wheel away in the wheelchair, but if the baby is on the CPAP or is on oxygen, then the oxygen trolley also has to be wheeled. So you may need more than one staff for this, very important job to safely transfer the mother or the surrogate from the labor room and to the MNCU. And as Dr. Chalani had in his lecture told, that it should be an area which is close to the labor room. So ideally, try to have it very close by, so the long distance does not from one building to another, it becomes much more challenging. Next, please. So I've already told you about the staff and the transportation, and of course, you will need to train them. The pediatric colleagues will have to train them about how, to transport on the CPAP. So those things are very important. Next, please. Yeah, so this picture you have already seen. The third part which I am going to talk about is the MNCU, where both the mother and the baby are cared together. So the baby is requiring the level 2 nursery care, but we have to remember that the mother is also an immediate post-partum lady who needs full monitoring and care from the obstetricians. So it is a care which both of them require 24/7. So this is the setup in our own hospital, which was shown to you. The video has been shown to you, the 12-bedded MNCU, which is functioning as a level 2 NICU. But here now, if we were lucky that we could have this space, which we could develop into a MNCU. But in many hospitals or in any facilities, if this kind of space is not available, it is always, feasible that either the cot is brought into the nursery or the MNCU, can be made within the postpartum wards itself. So if you have the desire to do it and you are convinced about this, I think it should not be difficult to even convert a few postpartum beds to MNCU. They can be, the pediatrics and the obstetric colleagues can work together. And if you have got, 2-3 cubicles, one cubicle for the postpartum can be converted. So this is, pardon, sir? Yeah. So next, please. Yeah. So here you are seeing the bed, how the mother is comfortably, seated, lying down at 45 degrees, sorry, and she is feeding the baby. So very easily from the KMC position, she can slip the baby to the breast and start the feeding. And you can also see the KMC chair. So at times she wants to walk, she is free to walk here. She can sit and relax in different positions. Otherwise, she will get tired in the same position on the bed. And when this trial was going on, which sir talked about, I would like to share one experience that, we were randomizing into the control group and the intervention group. So the mothers, the word went by that the mother and baby can stay together in the MNCU, but if it is the control group, the baby is in the nursery and mother is in the ward. So what sir said that, about anxiety and about the relaxation, I can't tell you, there were so many mothers who would ask us, please allow, somehow do something that we should come within the intervention group. We want to be with our baby. So that was, the level. And when you saw the video, I think you saw one emotional mother, how happy she was to hold the baby at her chest, these small babies, separating them from the mother at that early stage, it is very traumatic for the mother. So the well-being of the mother also lies in the baby being with her and zero separation. I think I would like to really stress that anything, her mental health will help her to even conquer any physical problems and things like high blood pressure and all. You see that I don't have any evidence, but this is one of the, things which we are working on, that whether the pre-eclampsia woman also will have a better BP control, staying with the baby. So these are the things for the future we are studying. Next, please. You have already seen this picture, that how the MNCU has been, totally made comfortable for the mother. So examination cubicle for any dressing post-cesarean, pantry for her, eating her food, warming it, and of course the bathing area. Next, please. Yes. So now this is the fourth thing about the couplet care. So here it is not mine or yours, it is ours. So the pediatric and the obstetrician are working as a team, and we are having the regular rounds from both the sides. Of course, the pediatricians are there round the clock within the MNCU, but the obstetricians are coming for the rounds. And who will come for round will be decision of the local facility, how they are taking care of postnatal, whether it is the same team or different team. But we have, delegated a same team for 1 month. Every month, one team is responsible for taking the rounds of this area of the mothers. And in the emergency hours after 4 p.m., we have shared our duty rosters. The emergency SR is responsible for any problem which may occur with the mother. But I would like to again say that we are transferring only stable mothers as of now, because the obstetrician are not there 24/7. So if the mother is very sick, then of course we defer it, and the surrogate can stay with the baby till then. But in most circumstances, we are able to shift the mother as soon as she is stable. Next, please. So we have also developed a package, essential care package for the immediate postnatal care. And in this, it is very important that the neonatal nurses are to be trained for the essential maternal care also. So what all, they have to be familiar with the drugs which the mother may require, and what all has to be, monitored in the mother. So those things are all taught to them. And of course, I spoke about the other rounds in the emergency hours as well as the routine hours. Next, please. Next, please. Yes, so this is one example of, the minimum care package which we developed in our hospital for the obstetrician as well as for the nurses who are there 24/7 within the MNCU. Next, please. And of course, this thing can only be successful if ongoing training is there, regular meetings between the pediatricians and the obstetricians to overcome any, glitches. And for the new staff which joins, we have the regular orientation and refresher training every 6 to 12 monthly for the older staff. Next, please. The cesarean mothers are a very special group. We are not, next, please. We are not able to, take them inside the MNCU immediately because of the strict monitoring which is required for the first 6 to 8 hours. So it is normally bringing the surrogate within the OT in the post-op area and then transferring the baby with the surrogate to the MNCU, and mother is transferred at a later date, later time. Normally we are trying that within 8 to 12 hours, we are able to shift the mother to the MNCU. And of course, once she goes there, we have to ensure that she is able to, she is comfortable and she doesn't have any post-operative pain, so that she can, establish the KMC with ease. Next, please. So this is the last slide, that the strong cooperation, coordination, and collaboration between the pediatricians and obstetricians is the cornerstone. So it is always not mine or yours. I think we have to work as a team, because the 9 months the baby is within the womb, and now is the time for her to take her baby home. I think the evidence shows that this kind of setup is very important for good outcome for the baby. So we are with our pediatric colleague for this intervention, which will help both the mother and the baby to go home together happily. Thank you so much.
Thank you so much, Dr. Jyotsna, for sharing your insights. And I'm sure there were so many apprehensions among the obstetricians. So it must have helped them a lot to understand that, yes, it is possible. And it is beneficial not only to the baby, but has the benefits to the mother. And it is really heartening to know that further studies are being done to look for the etiologies of the mother, how it can help. And definitely regarding the psychological and the postpartum depression, I must say that per se, by my clinical experience, I have seen that mothers do get better and they do build confidence. And I'm sure it's going to be a long way if we continue with this. Now, we have, as I said, now it will be a question answer session, and participants have put on some of the questions in the chat box. So, yeah. So some of the questions, initial questions, we can look. Some of the questions we have written.
Okay. So I think maybe we can, thanks,
So-
Dr. Shobna. There are a couple of questions which are already
So,
there.
just to interrupt, just before proceeding on the question, I would like to clarify the few things. That here the term MNCU was interchangeably used with MNCU. So basically it is mother in the newborn care unit. So what we would be following here, because we are catering to the level 2 facilities at our National Health Mission. So SNCU, the services we providing, we are talking about the services. So all the newborn care services, which we are right now providing at the special newborn care unit. So here the component of mother would be added. So it is not about, we are not talking about whether ventilator is there or not there. So we will be using the uniformly the term MNCU in the guidelines we will be releasing from here. And even in the revised FBNC guideline also, we have used the term MNCU, that is mother newborn care unit.
So the first question is that whether you are using this MNCU for the neonates who have the ventilators in MNCU.
So Dr. Sugandha, since you have recently scaled it up to tertiary care, so are you using ventilators in MNICU?
Okay, so SNCUs or the level 2 units, we do not have ventilators. So during the study, we did not have ventilators. It was a level 2 unit. Now, once we replicated this model for the tertiary care for the level 3, which we are doing right now, we have a 40-bedded outbound unit, which is level 3. So we have babies on ventilator also inside MNCU. Their mothers stay with the baby. KMC, we start presently only when they are shifted to non-invasive ventilation. We are not using with invasive. Otherwise, mother still stays even if the baby is on ventilator and takes care of other things on the ventilator.
And the next question is, does NHM provides fund for setting up MNICU?
Yes, we have the, as I told you before, that in 2018, we had a guidance note and we had the provision of setting up of MNCU. And right now, there were other questions. We are revising those guidelines, and we will be coming out soon with the operational guidelines, where that funding part of some of the new things which we will be added, like the cloth with the binder, which we say is on the GEM portal, the CPAP machines in the 30% of the beds. So we are in the process of updating of that guidelines, and will take few months after the financial approval that those would be out. But already there is a almost to 80% of the funding provision is already there of the MNCU. So a little more would be added to have as per the newer guidelines. Otherwise, funding is already there and it has been approved by certain stakeholders.
Okay. Another question is for the Chilani sir, that someone is asking that if the patient load is more than the number of beds, then how you are managing this?
Okay. So, it's ideally, there are two situations in which you are setting up the new mother newborn care unit. Now, in that case, of course, as I mentioned initially, that this is based on the number of deliveries and plus percentage of the babies you are getting from the outside or extramural births. Plus you keep a space for the expansion. So I do agree sometimes these beds they become less. So whatever I feel, sometimes when you start these facilities, mothers they prefer to get discharged from mother newborn care unit itself. So try the moment the baby becomes stable, try to shift this baby to KMC ward. Only then you can accommodate more and more babies in the MNCU. Otherwise, it will be a stagnation and you will be keeping only stable babies who require just the, I would say, KMC or maybe the tube feeding or cup feeding. But ideally, when we are looking at this, the sicker babies should be in the MNCU, get the advantage of that, and then you can shift these babies to the KMC ward. But what I would say, get to that confidence, initially you can start with milder cases like those babies who are on tube feeding or with minimum IV fluids or oxygen requirement for 24 hours. The moment you get confident, then you can go for the sicker babies on the CPAP and other things. Always start from the simpler things first. If the baby is on IV fluids, learn how to keep the baby in the KMC position. The moment you get confidence, then go to the next step. And here also, there is a provision. If you set up this unit, the team from Safdarjung Hospital, you can get onto the site, they can train you, or your site can visit Safdarjung Hospital and see how those things are happening. So once there is a cross learning and these things, you would be feeling more confident to work on that.
Thank you, sir. The next question is that what would be the minimum area per bed in this MNCU complex?
Yes, so as we know, as sir has also highlighted in the presentation, that it is the area for the baby care which is already there, along with the 100 square feet per bed of the mother. So if I'm talking about, now there are two kinds of beds here. 30% beds would be with the CPAP and the remaining would be the stable without the CPAP, we would say. So in the MNCU, the 220 square feet per mother baby diet is required if it is a normal bed, and 270 square feet per mother baby bed with non-invasive with the provision of CPAP. So we would say in a 12-bedded unit, approximately 4 CPAP machines would be required. So it would be totally calculated as per that. So 220 square feet for a normal bed and 270 in a bed with the CPAP.
Thank you, madam. The another question is for Sugandha, madam, that if baby is very sick, what would be the how to deal in front of the mother? For example, if baby they need to intubate, if they want to do the CPR, if they want to do some any other kind of the procedures, then how to deal these kind of situations?
This situation is same as you handle in PICU, pediatric intensive care unit. You have an attendant. Similarly, in wards, many times these incidents happen, and you have an attendant or the parent along with that. So what do we do? The same things we do in the NICU also now when mother is there, the way we PICU. So there we ask the mother if they want to be there in the when this procedure is going. We ask her if she wants to be there. We let her allow her to stay there. But some mothers opt that I don't want to see, I don't. Then we put a screen and then separate the baby by a screen and do the procedure. So it should be as per, I think, parents' choice. What do they want to? Many parents tell me, I want to be there. Mother tells me, I want to be there. Then we say, then you can stay there. So it should be dealt in the same situation for all the children in PICU or NACU.
Yeah,
and sometimes, Dr. Kapil, the critically sick babies who are there while in the level 2 care, they get shifted to the tertiary care already. So that's another situation actually, the way we see when the sicker babies from the SNCU, they will get shifted to the higher facility medical college.
Another question is that how to manage the entry of the relatives and the other persons in the MNC.
Yeah. So I think it's important, and you have to have the same type of culture as we maintain for the SNCU. So if you have a provision of the visiting hours, please do stick to that, that only that particular time. Keep the security guard, because we cannot allow the free flow of the relatives happening. So similarly, we have the presence of the mother there. So mother is taught about the moment she enters, she is taught about the asepsis protocol, right? And the relatives are, they are coming to this MNCU only between 4 to 5 or in the morning hours, the way the policy of the hospital is there. So that's the only way. Sometimes the relative want to talk to the mother. So if surrogate is inside, she can go outside and talk to the family in case there is some requirement, or she can go out if there is some investigation to be conducted by our obstetric colleagues. So those possibilities are there, but you have to have the same culture of the asepsis protocol maintenance as we do it for the SNCU.
Ma'am can take.
So one person from Odisha, they are asking if, for example, if mother is in the labor or in the labor room and in the transit to shifting to the SNCU or NICU and baby wants some KMC and other kind of a situation, can we have some surrogate? Can we take the service of surrogates?
Yes, so we have already highlighted about this, that you can start identifying the surrogate right when the patient is in labor. And especially for the cesarean mothers, we will need a surrogate because they cannot be shifted immediately to the MNCU. And we will need, as sir has very nicely highlighted about the previous question also about the relatives being there. So we have to remember that a mother who has had a cesarean does need care for herself also. So a presence of a surrogate who will start the KMC for the cesarean mother, and then the mother is shifted to the MNCU, but that surrogate who is already identified and who is now familiar with the protocol of your unit about how to maintain the asepsis can continue to care for the mother, whenever it is required, because for the initial hours, she may not be able to get up and do everything on her own. So she may also require the support in the initial 1 or 2 days. And yes, so definitely the question is very valid. The surrogate should be identified and we should encourage if the mother cannot start the KMC immediately.
Clear. Next question.
So the next question is from the Archana Misra. She is asking that whether the MNCU can be a part of PNC ward and MNCU should be a part of SNCU.
Okay. Yes, I think it's a important question. When we say MNCU currently, what we are meaning is it is a level 2 care unit. So all the inclusion criteria or the admission criteria to the baby for level 2 care nursery or SNCU is the same as for the MSNCU. When we say postnatal ward criteria, so for here I would say all babies who are between 1800 to 2500 grams, who are stable from the birth, they will directly go to the postnatal ward / KMC ward for the KMC provision. Second important thing is those babies who are stable in the MNCU have reached to the stage of the cup feeding or tube feeding, they can again go to the KMC ward. Now, depending upon some of the KMC ward, they have round the clock availability of the nursing colleague. So the moment the baby is off the respiratory support and the baby has gone on to the total oral feeds, can be managed in the KMC ward as per the listed criteria of the KMC ward. So what I understand from your question, Archana, that MNCU is to be treated as same as SNCU as far as the level of 2 care of the baby goes. Postnatal care and KMC ward is a further step down, right? Hope that is answered your question.
So another important question is that Neti Agarwal is asking that if the nursing staff is also, there is a shortage of nursing staff as well as they have shortage of residents, medical officers, and they have, if the facility have NICU facilities also, so lots of work is, level 3 works are also there. So how they can operationalize the MNCU along with the same staff and doctor and
See, the minimum staff of the SNCU has to be there. I mean, we cannot say that without medical officer, without nursing officer, you can run the even SNCU. So SNCU oblique MSNCU, what we are saying, it is the same staff which we are talking about. So without particular staff, yes, it does happen. Sometimes there is shortage of the staff is there, but you cannot run without a particular norm which the Government of India has already set in. So that particular staff has to be present there. Only then the functionality of this. Only thing is that mother is here now additional, person who can look after the other components which are non-critical, like giving the tube feeding or putting up an IV line is definitely a job of the nursing colleague or the healthcare provider. But changing the diaper or the expression of the milk or feeding by the cup, that definitely can be done by the mother, and the nursing colleague can be relieved from such things and she can spend more time on the monitoring end. Right?
so the another question is from the Pawan. Pawan is asking that if facility already have SNCU or already have some other setup of SNCU and MNCU, then what would be the message for them?
So I can answer
This
that.
is the previous MNC that.
Yes.
Yeah.
So basically, see, there are the situation now in existing situation, there will be 2 or 3 situations we will encounter. First of all, you have an existing SNCU along in your unit and you want to expand it further. So one of the options in expansion, suppose you have a 12-bedded unit and you have asked for the expansion to the 20 or the 24-bedded unit. So that as an expansion of the existing SNCU, you can have a mother newborn care unit along with it. And but the guidelines, as per these new guidelines, where mother bed along with the equipment, this minimal equipment and the KMC chair would be required. Second thing is in some of the units, MNCU, like we have already, as per our data, we have already 150 plus MNCU as per the old guidance note exists throughout the country. So as per those, few changes need to be done in the infrastructure, because in those MNCU, mostly the mother's bed are lying and there are 1 or 2 warmers lying at the side. So it's more of a step down unit kind of thing which is there, rather than the mother newborn care unit providing level 2 care. So those minimal changes would be required for the upgradation of those units, for which if required, you can ask in the supplementary PIP for the upgradation as per the new norms. Third thing could be you have a MCH wing in development, or you have a space where you want to come up with the new MNCU, which can be done as per the new guidelines altogether. So all these things, we would be, when we will be coming out with the operational guideline, we are going to list all these 3 situations, because we are in the variation kind of thing. So if you have a special newborn care unit, you can have an expansion in the adjoining. For the MNCU, you can have a new mother newborn care unit as well. And you can restructure your previous special newborn care unit as per these guidelines if you want so. So all the options would be given to you for the clarity in the new operational guideline, which will be there in 2-3 months time to available. I hope the query is being cleared.
I think there are a few more.
And to start with, you can even start this mother newborn care unit with few beds, starting with the 6 beds. If you don't want to expand, just to pilot it and want to see how it goes. So even you can start with the few number of beds.
So the other question is from Dr. Renu Srivastav. She is asking that the binders are recommended for the home KMC also.
See, Dr. Renu, now there are two ways actually to look at it, that when we say community initiated KMC or when the babies are discharged from the facility. Now, those babies which are discharged from the facility, generally the KMC garments are provided from the health facility. This is what I'm trying to say, that it will take some time the saturation to happen. So currently, because this is at our place, it is functional. So what we are doing is that during the time when the baby is in MNCU, 2 sets of garment is given and that mother takes home also. Daily it gets changed, washed, and it is taken. Now you are talking about there could be another scenario where the birth has happened at home, right? And the KMC is to be initiated at place. So now this particular, the 2 set of garment which was shown in the video, that is especially for the, sick babies. But can we use this for stable babies? Yes, we can do it. But sometimes for the home initiated KMC, in the trial, they use the local clothes to maintain these positions, because these babies were stable and they were, utilize that. So I would say those babies, when we are initiating the KMC from the beginning, they also require the, neck to be in the slightly extended position and monitoring. So one has to, one can discuss and further debate on this about the home initiated KMC, which type of, because all the cost and other things are equally important. So I would say that one can discuss this issue, what you are asking, very important question, but definitely from the facility, we are providing these garments to be taken for the home.
Another question is from Dr. Pradeep Chaudhary, Nodal Officer, Rajasthan. We want to ask that how to go about establishment of the MNCU, whether we want to first set up at the medical college, at the second we need to set up at the district level or sub-district level. So what is the take-home message for the participants?
Yeah. Dr. Pradeep, as you have heard in the lecture, that when this evidence has been generated on the level 2 care itself, just wait, couple. The level has been generated on the level 2 care itself, that is the care providing minus ventilation, so till the CPAP. And in the district hospitals, SNCU, the care is provided level 2 is only. So there is no doubt about the evidence of having the benefit in the district hospital. Coming to your query that the doctor-nurse ratio and care is better than the district hospital, for that I don't agree actually, because if you actually have visited a medical college, I think the crowd and in fact this initiative is there going to help the medical college, decongestion of the medical colleges itself, because all the sick babies which are requiring, they are reaching directly the medical colleges, and in fact we need to utilize our district hospital, and the involvement of the mother has to be more for the level 2 care. So in fact, whenever I have visited the medical colleges, vis-a-vis our SNCU, the care at the SNCU, and this is well known everywhere that the district hospital are providing much better care because of the availability of the infrastructure and the HR through the NHM in a very systematic way. So I think there is no doubt of evidence, and yes, we will be, I'm seeing the next question, we will be coming out. Yeah. Sorry.
Yeah, I just want to add, Dr. Pradeep, it is a very important question which you have raised. But I'm just taking from Dr. Shobna, we cannot wait for these sequential things in the way it should happen. Rather, I would say concurrently, these things should happen, because now there is enough evidence. So if we can find the opportunity, if we can find the place, and generally the people, they look upon the district hospital and medical college. If they work concurrently and if they have the space available, I think it should be started simultaneously both places rather than having from the medical college, because large number of our babies, they are at a district level where it is level 2 care, and people will be apprehensive for the tertiary care. I would say that is the next step. The moment you are confident with the level 2 care babies with mother, I think then you should go for level 3. But simultaneously, as it has been there in Safdarjung Hospital, we also started as a trial as level 2. But now with the confidence and this, we have also replicated for the tertiary care. So I think that policy would be better for this.
So another question is for Josna Suri madam, that whether all mothers should be admitted in the SNCU irrespective of the size of the baby, whether baby is more than 2.5 kg or less than 2.5 kg. What would be the benefit if we admit the more than 2.5 kg babies, mothers in the SNCU?
So I think the concept of MNCU is not synonymous with KMC. So KMC is very important for the low birth weight baby, but MNCU is the concept that the mother remains with the baby and there is a policy of zero separation. So even if the baby doesn't require the KMC and it is a good weight baby, then also there is always the benefit for both the mother as well as the baby to have be together and zero separation. I think those things have been highlighted.
So, Dr. Joseph, I'll totally agree with you. I think the answer is very simple that yes, all babies, all mothers with babies weight less than 2.5, because majority of these babies would be stable. If we see 1800 to 2500 grams, so at least make the KMC started in the facility so that it can be continued at home. That's the major important thing. Secondly, what about those babies who are just for assisted feeding in the MNCU or SNCU? Those babies also, the mother's presence would be required. So I think the answer for that is yes.
So from Assam, someone is asking that if baby is hemodynamically unstable, then what they supposed to do? Whether they need to shift this baby to the SNCU, MNCU, or they need to refer or send to the NICU?
Same thing what they are currently doing it. See, if any baby, because Asha cannot decide that this baby to be going to the level 2 or level 3. So I think for her, Asha, if she knows that baby is not well, then this baby has to go to the nearest facility where newborn care facility is there. Whether it is level 2 or level 3, because sending the baby to the medical college without stabilizing, that will be catastrophic. So if the nearby facility is of the SNCU, I think the baby should be referred to that place. Let the doctor there decide whether it is really level 2 or level 3. Yeah.
So another question is from Dr. Nimisha Goyal. She is asking that along with the planning of the new operational guideline, whether ministry is also planning to have some other training related things also. Ministry is thinking. What is the ministry's take?
Yeah, Dr. Nimisha, we'll soon be coming. We are working on this for the training package. Definitely, as you was told during the lectures also, that training and capacity building would be required to gain the confidence about the processes. So we are in the process of developing the training document, and definitely we have the persons from the maternal health division as a part of that, because it is definitely a joint venture where mother is an inherent part.
So again, someone is asking that whether the KMC ward or HDU and MNCU all are same, or is there any?
See, KMC ward and HDU cannot be the same. KMC ward is a step down actually. So I would say high dependency unit, some people they call it, of course with the ventilatory support care. So that cannot be the same actually. So high dependency is somewhere between level 2, level 3 or level 2 plus, whereas KMC ward is a step down from FD. Yeah.
So, Archana Misra is again asking whether the new building need to be established, or is there any plan for making a renovation or making a makeshift arrangement in the existing building? What to do?
So definitely, so those requirements are there for the infrastructure, so that needs to be planned as per the space available. So that space needs to be seen definitely at the level of the facility. So are there possibility of, so those norms actually can be seen at the individual facility, because space cannot be created overnight. So you have to see that how well you can start with the, that's why I said initially to start with, it can be started with few number of beds. In the colleges having MCH wings, it would be easier to start with, because as they are multi-structure. In other buildings, it needs to be seen where it can be started.
So another question is from Ashish Jain. He is asking if at the facility, if there is a severe space crunch, then how to go about?
Would you like to know?
Yeah, when the space is not available in the proportion of the admission, what is the criteria for the trial with similar age, as hospitals may not have enough space to take the load. Dr. Ashish, I would say I agree with you that, these space crunch is always there. Same was there when we had a, setup of this trial. But believe me, if we talk to number one, our immediate colleague, that is obstetric colleague. Number two, if you talk to the hospital administration, there are some space where the roof of the many, buildings, which can allow an extra space building to be structured, made. That's what we did it, because in our place also, it was an IVF center and the roof was lying vacant. And then we took the permission from the OBG department and the civil engineer and electrical engineer, involve them, because a lot of space sometimes is there. There are a lot of unused equipment in their many stores, which we are not in a habit of disposing it of. So make a move to these obstetric ward jointly with our obstetric colleagues, or you do it with the hospital administration. Nowadays, because the ministry has taken it on the board, the ICMR agrees to this. Funds are not the issue. It is only you have to find out the space with the hospital administration so that you can get a space and get it. Without that, of course, it will be difficult to, put it mother's bed in the existing NICU and compromise the number of the beds in the NICU. That we are not saying that.
Regarding the many questions I've asked about the inborn and the outborn distinction, because in our special newborn unit, generally they are not distinct, keeping not distinction. So they are asking whether we can put in the same MNCU the baby who's been born inside and outside.
Yes.
So it's the admission criteria are the same, right, Dr. Subhra?
Yes, and now there is, as Dr. Shobana said, this concept is now obsolete. It is only for logistic reasons if you want to have separate, because an inborn you want near labor rooms and OT, outborn you want where the newborns are coming to the emergency. If it is the same place, then there is no concept of now septic nursery, non-septic, inborn, outborn. You have to maintain barrier nursing between every two babies irrespective of site of admission.
Yeah, so I think message is clear, cohorting is not done. And because the infection moves from hand to another baby, so that I think asepsis routine, that should be the, I think, culture, that everybody is talking about the asepsis and asepsis. That should be the norm.
So next question is that if the baby is sick and required the chest raise, then how we can see, how we can save the mothers by this exposure.
So
The same
Sugandha,
thing-
this is a question because what time you do separate the baby?
Yes. So there are, we have not discussed that much. What are the indications of separation? How do we reduce? This is one of the indication for separation of the baby and the mother. So the way you ask your doctors and nurses to leave the room when you are doing X-rays, the same way mothers also leave the room when X-rays are done. So this is one indication of separation, and you should cohort all the activities which require separation. So mothers are not exposed to X-rays for this. They are separated at that time.
But that phototherapy also requires separation.
Similarly, there are other reasons. Now this question has come up. So you will have a lot of reasons where separation is required, like phototherapy. You can't give phototherapy in KMC position, which is a very common reason of separation for preterm babies. And also you need separation when babies require some procedures which you cannot do on the KMC position, like putting an IV line, intubating a baby. So for these things also we separate. But here I will say two important things practically which work when we run MNCU, because otherwise there is too much separation. One thing is you should do cohorting of activities which require separation. It is not doctor comes, separates, then the nurse comes after half an hour, separates. So babies will get, unstable if you keep separating them so often. So the MNCU routine has to be made in such a way that in the morning or at any given time when separation happens, all the activities which require separation should be done in one go, like cohorting of activities. Number two, the moment the reason of separation goes, there should be a culture of putting the baby back to KMC. Otherwise, what happens? Somebody separates for maybe mother wants to take bath or something. And after the thing is over, nobody remembers to put the baby back to KMC. So these are the important things you should keep in
With the
mind.
permission of chair, I may request Meena Eco team that please give the unmute right to all the participants so that they can unmute themselves and that they can ask questions.
Okay, participants have raised their hands, so first.
Yeah. So yeah, there are hand raised actually, so we'll take up those questions first.
Okay, I'm giving them the unmute option.
Okay. Can we have the people?
Yes, ma'am, participants can unmute themselves now.
So now the participants can unmute
Dr.
themselves. and-
Mamta Paul is one.
I think Mamta Paul is there. She raised the hand if she want to ask any question.
Dr. Mamta, please go ahead.
Hello, sir.
Yes, Mamta, please.
दंतेवाड़ा से बोल रहे हैं सर, छत्तीसगढ़।
Okay, great. Hope the
अभी
audio was good.
अभी हमारे यूनिट में एमएनसीयू नहीं है सर, तो हम स्टेप डाउन में ही रखते हैं बच्चों को।
Mhm.
तो अभी खुलने के बाद ही ये सब हम कर पाएंगे सर।
Yes. So, Dr. Mamta, you're right, because this is just a new concept, and fortunately, Government of India has taken it proactively now to take this further. So please discuss with your obstetric colleagues and the administrators, and then take a call and find out the place. And there is a provision of, funds also. So funds allocation. So please do that. And I think Dr. Shobna is also going to announce that those of you who want to have a visit to these places and see how the processes are being done. Once you see, then only you believe. And then only you can see, okay, now I'll go to the site and try to find out a space, and maybe the process can be initiated. We have got already operational guidelines which mentions all the details of the space, HR, then even the processes. So, and which Dr. Jyotsna Suri mentioned about the care package for the mother. So all these things are there, so which can be easily shared by the ministry. Over.
जी हाँ सर, थैंक यू सर। मैं सिस्टर इंचार्ज हूँ सर वार्ड की।
Okay, good, Mamta. I think मैं एक और भी ममता आपसे कहना चाहूंगा, जरूरी नहीं है कि हमें MNCU बनाना तभी हम माँ और बच्चे को इकट्ठा रखना शुरू करेंगे।
जी
There are many places like in the postnatal ward जहाँ पे बच्चे हमारे होते हैं जब तक हम डिस्चार्ज क्राइटेरिया की वेट करते हैं। अननेसेसरली वो बच्चों को अगर नर्सरी में रखा जाता है और देख रहे हैं कि हम माँ आ सकती है अंदर मैक्सिमम टाइम के लिए, जब तक देखो पूरा बेड नहीं क्रिएटेड है मदर की एंट्री बिल्कुल फ्री होनी चाहिए इन दी MNCU। सो ये जो कंसेप्ट है ना माँ और बेबी को किसी तरह से इकट्ठा लाने की और मैक्सिमम टाइम लाना वो बहुत जरूरी है। आई थिंक अगर एक हम उद्देश्य बना लें कि माँ और बच्चे को हमने अलग नहीं करना, नेचर ने तो कॉर्ड के साथ रखा था, हमने कॉर्ड कट करके दोनों को अलग अलग डोमेन में भेज दिया। आई थिंक इसको वापस ले आना बहुत जरूरी है। लेट अस नॉट प्ले विद द नेचर।
जी हाँ सर, हम लोग ज्यादा से ज्यादा मदर के पास ही रखते हैं सर बेबी को।
गुड गुड।
Thank you.
जी
So now we can move to the
स्टेट 5।
थैंक यू सर।
मोस्टली क्वेश्चन जो थे चैट में भी हैव एनकाउंटर्ड, पर फिर भी एक बार मैं स्टेट वाइज पूछना चाहूंगी। एक तो ये चीज कि आप लोगों में से कोई भी आगे सवाल हो या दिल्ली आके मदर न्यूबॉर्न केयर यूनिट अगर आपका चक्कर लग रहा हो देखना चाहे तो वो विजिट हम फैसिलिटेट कर सकते हैं। अगर स्टेट गवर्नमेंट की तरफ से आप आना चाहें तो सफदरजंग हॉस्पिटल में विजिट कराया जा सकता है। दूसरी चीज, एक बार मैं सारी स्टेट्स का एक करके नाम लूंगी, अगर वहाँ के स्टेट नोडल ऑफिसर्स या कोई एडमिनिस्ट्रेटर या पॉलिसी से कुछ सवाल पूछना और चाहते हैं तो दे कैन अनम्यूट देमसेल्व्स एंड कैन आस्क। असम से डॉक्टर हलीम इज देयर, उन्होंने वैसे क्वेश्चन भी लिखा था, अगर किसी का कुछ हो तो यू कैन आस्क नाउ। असम से, मध्य प्रदेश, या डॉक्टर हलीम, एनी कमेंट फ्रॉम यू?
यस मैम, हम लोग का एक इशू था लाइक पहले जो हम लोग के एसेंस में कॉन्सेप्ट था स्टेप डाउन का, वो अब
थोड़ा सा लाउड डॉक्टर हलीम, थोड़ी सी आपकी वॉइस कम आ रही है, थोड़ा सा लाउड।
मैम हम लोग का असम में मैम एक्चुअली एसेंस में क्या होता था, स्टेप डाउन होता है एंड देन अगर वी इफ यू मेक दिस MNCUs will there be a similar concept like step down मैम?
हलीम आप रिपीट करेंगे क्वेश्चन? सेकंड पार्ट आप
Have a step down. Is step down same as MNCU?
नहीं, आई थिंक
Clarify the question.
you want to say?
Okay. So step down with MNCU is basically a SNCU only with the mother. So you cannot, and step down you will still need after making MNCU, because if you keep the babies still discharged inside MNCU, you will never get the beds for the sicker babies coming to SNCU. So MNCU is something absolutely similar to SNCU for indication of admission. For transfer out to step down ward, so step down ward cannot be used as MNCU. We need to make MNCU in place of SNCU, or till we have more space, maybe both together, that some babies in MNCU as many as possible. Hope that answers your question.
Ma'am, there's one more question, ma'am. Ma'am, MNCUs are supposed to be in the same floor as labor rooms and CS/OTs, ma'am. For this year, we have proposed one MNCU in Silchar Medical College, and where there is space in another floor. Can that be done, ma'am?
So as far as possible, that was only a guideline. If you have a space on the same floor, it is good. But if you do not have, you can go to one step higher also. So next floor पे आप जा सकते हैं, ठीक है? But I would say कि priority थी वो वाली, but it's not mandatory, ठीक है? तो जैसे same floor पे आपका labor room, OT, everything is postnatal ward, but ये वाली luxury कई बार नहीं available होती. But then please go to the next floor and if you have that space there. But मेरा जो एक सबसे जो है सवाल, इसको आप स्टेप डाउन सोच रहे हैं कि माँ अगर बच्चे के साथ है तो ये KMC वार्ड की तरह हो गया या पोस्टनेटल वार्ड नहीं। आज की जो डिस्कशन थी कि SNCU के जो क्राइटेरिया हमारे एडमिशंस के हैं वो ही MNCU के, राइट?
Sir, actually due to poor network, मेरा क्वेश्चन
इम्पोर्टेंट मैसेज लेके जाना चाहिए।
सर नेटवर्क का इशू के लिए मेरा क्वेश्चन थोड़ा मतलब थोड़ा अलग चला गया, बट एक्चुअली द थिंग इज दैट माय क्वेश्चन वाज दैट हमारा एसएनसी में जो स्टेप डाउन रहता है फॉर एमएनसीयू आल्सो विल यू हैव सिमिलर फैसिलिटी लाइक स्टेप डाउन?
डॉक्टर हलीम, ये स्पेस पे एक्चुअली डिपेंड करेगा। अगर आपके पास एसएनसीयू और एमएनसीयू साथ साथ है तो सिंगल स्टेप डाउन कैन वर्क टिल यू हैव स्पेस, क्योंकि एट वन गो यू कैन नॉट हैव ऑल दी स्पेस, राइट? स्टेप डाउन में बेसिकली मदर्स बेड रहते हैं, ठीक है? तो अगर आप सेम जगह बना रहे हो और कॉमन आपका स्टेप डाउन है तो दैट विल वर्क, उसको आपको दोबारा नहीं बनाना पड़ेगा, क्योंकि स्पेस इज वन ऑफ द इशू व्हिच यू नीड टू सी। अदरवाइज हम एमएनसीयू से डायरेक्टली भी डिस्चार्ज कर सकते हैं, डिपेंडिंग ऑन अगर बेबी अगर आपके पास नहीं है तो एमएनसीयू से भी डायरेक्टली डिस्चार्ज कर सकते हैं, अगर आपकी ओवर क्राउडिंग नहीं हो रही है।
Yes.
वो प्रॉब्लम मेडिकल कॉलेजेस में ज्यादा होती है, क्योंकि ज्यादा बेबीज रहते हैं, तो आपको स्टेप डाउन में और सिक बेबीज को अकोमोडेट करने के लिए जल्दी जल्दी शिफ्ट करना पड़ता है। वी हैव मध्य प्रदेश, मध्य प्रदेश, डॉक्टर हिमानी सिंह। Anyone from Madhya Pradesh?
Yes, Dr. Shobna, I'm Dr. Archana Mishra, State Program Officer of Maternal Health.
Yeah, Dr. Archana.
Your team has already replied to my questions. I was just worried about the infrastructure. In the new MCH building, we will surely ensure, but in the existing one, we will see how we can operationalize MNCUs, because we have mothers ward in our district hospital where when the women gets discharged, our PNC ward, and the baby is still in the SNCU, the women, the mother's warding is being used, or the suppose the baby is referred from other facility, the mother is admitted in mother's ward. So these mother's ward, we will just look at it how it can be converted time being for as a MNCU. So we will look at it.
Anyone from Uttar Pradesh? Anyone from Uttar Pradesh? Or
Yes,
any
ma'am.
other state? This girl we have Odisha, Bihar, Rajasthan.
Yes, madam. Good afternoon.
Who is there? Please introduce. Yeah.
Madam, Dr. Aditya Mahapatra,
Yes, doctor. Yes, Dr. Mahapatra, please.
thank you, madam, for this eye-opening workshop. Actually, we have visited this Safdarjung Hospital 1 year back, and Dr. Delani and his team also explained about the MNCU. We have planned 3 MNCU this year in PIP, and very soon with engineers and our stakeholders of the unit, we will visit Safdarjung, and I will contact Dr. Chelani when we are visiting. And it will be better if you can spare some time and explain our participants.
Good.
Sure, doctor. Sure. You can send a mail also. We'll coordinate that visit. Yes.
Thank you.
Anyone? Yeah. Thank you. Anyone from Bihar, Rajasthan, Punjab, Delhi, Sikkim?
Good afternoon, ma'am. Dr. VP Rai from Bihar.
Yes, Dr. Rai.
सो मैम हम लोग तो बहुत सारे MCH विंग में शिफ्ट कर रहे हैं, नए MCH विंग हैंडओवर हो रहे हैं, तो वहाँ अपने पास स्पेस पर्याप्त है, एम्पल है, जहाँ पर हम इसको इनिशिएट कर सकते हैं। अदरवाइज मेरे यहाँ नए MNCU तो कंस्ट्रक्ट हो रहे हैं, बट वो सभी सब डिस्ट्रिक्ट लेवल पर हैं और उनमें अभी टाइम है बनने में, लेकिन जो MCH विंग में हमारे पास टाइम काफ़ी स्पेस है और हम लोग इसको शुरू कर सकते हैं।
बिल्कुल बिल्कुल डॉक्टर राय, यही पर्पस था, क्योंकि एमसीएच विंग कई जगह कंस्ट्रक्शन में आ रहे हैं जहाँ पे स्पेस की प्रॉब्लम नहीं है, तो अगर अभी से इंफ्रास्ट्रक्चर एंड ये चीजें देखी जाएगी तो वहाँ पे बहुत सक्सेसफुली वी कैन स्टार्ट।
जी, श्योर मैम, श्योर।
थैंक यू।
Yes, ma'am. I am from UP, from Institute of Medical Sciences, Greater Noida.
Yes.
Ma'am, I wanted to ask one thing. Ma'am, how can we take funds for supplementary PIPs? Since we are running a 12-bedded SNCU right now. And for we have a MNCU as well. So if I want to upgrade it further, so how can you take funds from this thing, your supplementary PIPs? You said no.
You have to contact your state NHM officer, Dr. Ojha. You are from UP now. So you have to communicate the plan to them and they will apply in the supplementary PIP.
Okay, thank you.
Anyone else? Yes.
Ma'am, good afternoon. I'm Dr. Shashikant Dhir from Faridkot Medical College. It's in Punjab, ma'am.
Yes.
So, few years ago, we had been given funds for this setting up of MNCU, but under PIP 9, but those funds never came to us. So we had ample space, but we could not start because of this. Ma'am, what should we do to get those funds?
We have Dr. Inderdeep. I think Dr.
Ma'am, their
Inderdeep.
file was already moved, but since we did not receive any amount from the central ministry for the past 1.5 years, as it is known to everybody, that our funds have been stopped at the central level, so we could not leverage them further now.
So let's hope this year we would be able to do so.
Yes, ma'am.
Any other state? Otherwise, we can have concluding remarks.
Ma'am from Rajasthan.
Yes, Dr. Pradeep.
Ma'am, we have already approved 36 mother newborn care units as it came as concept in 2018. After that, we had approval of that, and 32 of them has been constructed, and we'll be utilizing them as this new MNICU concept. Ma'am, my request was for medical college was for one more reason, because this is new concept, ma'am. And if the tertiary care units will be practicing it and showing an example, because there are training center also. So our SNCUs staffs get trained there. So when they will be visiting that facility in our medical college at highest level, it will inculcate some confidence in them, and they will be able to practice bubble CPAP with KMC and intensive care with KMC. That's why my humble request is that please, we should push it from highest level so that it can become a practice and it can be done till the lowest level, ma'am.
Yeah, Dr. Pradeep, definitely there is no doubt about pushing it from the highest level. That is why it has come, it is there in the 5-year plan. And regarding the medical college, we do give under NHM, the SNCU, the newborn care. So you are the one actually at the state level who will be supporting the medical colleges in establishing MNCU. Yes, so if you can propose in the PIP, we would definitely sanction it. The medical colleges need to see the space and the infrastructure for this. But under NHM, we do support till level 2 care even in the medical colleges. So,
ma'am, I have already proposed and get approval, but that is older MNCUs, no? And this new concept of MNICU should be practiced in medical college first.
No, Dr. Pradeep. Here at the national level, it's making it clear again. At the national level, right now, we will be proposing till level 2 care MNCU. Medical colleges to take up them or not till the NICU, it's up to them. So right now at the NHM level, definitely this webinar explained about all the things which is happening. But since the evidence generated is for the level 2 care till now, so to start with, we will be taking up with the level 2 care, even at the medical colleges or district hospital, not a problem, right? So for the sick babies, we have to first get confident in that. And then moving forward, it's up to the medical college professors that they would like to take it forward for their NICUs, right? Definitely, they can be training center. There is no doubt about it. And they can establish MNCU to decongest their level 3 and level 4 unit, to decongest, they can have a separate MNCU even in the medical college.
Excuse me, ma'am, I have a question for you.
Dr. Inderdeep, so I hope, Dr. Pradeep, your query is clear. Otherwise, I would suggest to have a visit at the servicing hospital so to give it more clarity that under NHM, you are giving for special newborn care units.
Ma'am, we all know that, medical college has different administrative structure. And if we are not able to, convince them to run this unit, because they are working as training center also, and they are mainly running the NICUs, ma'am. they have very few SNCU, or
See,
they don't
if
even
I
call
would
them
say,
SNCU, ma'am.
Dr. Pradeep, I think there are many states to name with Gujarat, even in South, Nagpur. I've been to many states where even in the Jammu and Kashmir, where NICU is running and SNCU is running by the medical colleges, and they have these special newborn care units being run by the NHM only, because definitely they have two. One unit is one above the, even in the Vijayawada. There's so many places I have visited. There is a NICU running and there are special newborn care units simultaneously. Definitely there you can have a MNCU and they can conduct training roles. Right?
Ma'am. Yeah, ma'am.
Yeah, Dr. Indrajit, you were telling.
Yes, ma'am. Actually, it is again regarding the medical college only, and we were talking about the special package for the states, for the 11 states. Ma'am, one medical college administrator, they want to propose a separate MCH wing. So I have to propose it in the maternal side or the child health side, because they actually have a lot of space available, but they actually need a 300-bedded new MCH wing, because their existing visited, it is quite,
Dr. Indrajit, for
old,
the
and it's not a practical thing to run.
Dr. Indrajit, for these individual issues, we'll talk separately, right? About the PIP and these issues. We can talk separately then in which head and how it will go. Right?
No, I just wanted to tell Dr. Pradeep. I mean,
Because otherwise, ma'am, there is no space to have MNCU in the existing building. Okay, ma'am.
Dr. Pradeep, I was just thinking, yes, the medical college also should have it, because now there enough evidence is there, right? And if you have a space, and as Dr. Shobna is saying, under the NHM, even in medical colleges, you can develop this unit. And as the confidence goes up, the way we have done it, then similarly, you can also take, rather, the way now WHO is looking, it is not only the low birth weight baby should be with the mother. Each low birth weight baby and sick baby, both should be with the mother. So that's the actual dream we should, aim for. But today, if I have got, the limited resources, I would put first on the small and, sick babies who are admitted in the SNCUs. Next step, yes, as you are saying, Pradeep, I totally agree with you. If your medical college can have the space under the NHM, you can develop the unit.
Sir, just a simple request, just put this in guideline that a medical college as well as DH should be start with this unit on priority. Yes.
Okay. Okay.
Yes.
Thank you. So I think we can now conclude. Many queries will keep on coming, so we'll keep on dealing with them, and as and when you proceed further. So I hope this exhaustive discussion of 2.5 hours was basically a sensitization how it actually looked like, and to clear some myths which were there, that it is a step down. How is it possible? Mother can be brought in. So I'm very sure with the intensive discussion and so much efforts by the experts, many of your queries might have been sorted out, and I'm sure they would be available further to clear the things as and when arise when you start with. So with this thing, I would actually like to thank our Joint Secretary, Meera Madam, who is very much there with us and supporting throughout in this endeavor to take it forward in a very timely and systematic manner throughout the country. Thank you, ma'am, for your time and guidance. Thank you to my experts, Dr. Harish Chalani sir, Dr. Jyotsna Suri madam, Dr. Sugandha Arya, for taking out time in spite of being so busy, clinical and otherwise in their practice. They came out to share insights with all of you and to clear their doubts, and for throughout their help. I'm sure they will be there with you further. To WHO, Dr. Dipti, for providing the support to always to the cause for the country, to all my nodal officers from all these states, Assam, Madhya Pradesh, UP, Chhattisgarh, Odisha, Bihar, Rajasthan, Punjab, Delhi, Sikkim, who joined so enthusiastically and propose the question. So that shows the commitment you all are having to improve the neonatal care in your state. So definitely more questions shows the more and more enthusiasm and the collaboration which we all require to move forward. So, and to the definitely the technical team of the ECO Zoom, which always provide us a very good platform to move forward, to Dr. Kapil Joshi, who's always there doing all the background work for our team. And he will be always in connect with you for your day-to-day, all the questions. So aligning you with the experts. So I'm sure, I hope I am not missing out on something. So thank you all for joining. And I'm sure together we would be able to take this newborn care to the next level and achieve the single digit NMR before 2030. Thank you all.
Thank you, ma'am. This the content can
Thank
be
you, ma'am.
added in the FBNC training also, ma'am.
Yes, we have already added this content of new revised KMC guidelines in the new FBNC guidelines, which we have released, and we are starting with the regional facility-based newborn care workshops right from the June. We have a first in the Assam. So we would be having these regional workshops. We'll be completing till September with the new FBNC guidelines, where this concept of MNCUs already we have incorporated. The operational kit would take a little more time because it needs to gone through various formalities, as it has budgetary provisions. So it goes through different, as you know, stations. So it will take another 2 to 3 months. But you have those revised guidelines where all these things are there when you go through it. And for day-to-day queries, we are always there for you. Thank you all.
Thank you, ma'am. Thank you.
Thank you.
Thank you, ma'am. Thank you.
Thank you, everyone.
With the permission of chair, now I'm requesting Meera Eco team to kindly.
Okay, I'm ending the meeting. Okay.
Please end.